Good evening, everybody, and welcome to today's episode of Marvelous Medicine. We are extremely privileged to have Dr. A.Ramachandran, Chairman Dr. A.Ramachandran's Diabetes Hospitals and President of the India Diabetes Research Foundation, Chennai. Dr. Ramachandran did his MBBS from JIPMER Pondicherry and his MD General Medicine from Madras Medical College. He did his FRCP at London and Edinburgh and then went on to do his residency in endocrinology at the University of Nebraska. He has done his PhD and received the Doctor of Science, which is the highest degree awarded by the MGR Medical University. Dr. Ramachandran has published more than 400 papers to date and has received several national and international awards for his research and preventive interventions in diabetes. The Indian Diabetes Prevention Program conducted by him has contributed significantly to the understanding of the primary preventive strategies specifically effective in the Indian population. We often talk of absence of Indian data when we discuss about any disease or intervention. Dr. Ramachandran and his team have made sure that we have huge data on every aspect of diabetes in India. They have conducted a series of urban and rural epidemiological studies on the pathogenesis, risk factors, and temporal changes in the prevalence of diabetes, pre-diabetes, and cardiovascular risk factors specific to India. His study of using mobile technology for lifestyle modification and prevention of type 2 diabetes has been a pioneering contribution showing the role of information technology in health. Tonight, he's going to talk to us about his research on a cutting-edge topic. Is diabetes an inflammatory disease? Biomarkers tell the story. Thank you so much, Dr. Ramachandran, for readily accepting to give this talk for Marvelous Medicine. Moderating the session will be Dr. Jayashree Gopal. She's the director at DiabEndo India, Institute for Diabetes, Endocrine, Metabolic and Lifestyle Diseases, and a consultant endocrinologist and diabetologist at Apollo Hospitals, Chennai. She's the Associate Dean of Teaching and Research, MD Diabetes Research Center, Chennai. She did her MBBS from Madras Medical College, and she's a diplomate of the American Board in Internal Medicine, Endocrinology, and Diabetes. She's the founder member of the Indian Menopause Society, Chennai chapter. She has written several book chapters and published several papers in national and international journals on medical matters, and has even published a romantic fiction novel called To Laugh Again. She has been a part of several research projects and has presented several papers and delivered many lectures in national and international fora. Thank you, Dr. Jayashree, for joining us today.
Thank you so much. Thank you.
Our co-moderator is Dr. Ravi Sanchez, who's a familiar face for all Marvelous Medicine viewers. He's a clinical director and distinguished scientist, diabetes, endocrinology, and women's health at Merck Research Labs, New Jersey, USA since 2007. He did his MBBS from JIPMER Pondicherry and his MD Pediatrics from PGI Chandigarh. He did his residency in pediatrics in SUNY Stonebrook, New York, and fellowship in pediatric endocrinology at IUSM Riley Hospital for Children, Indianapolis. After being in clinical and faculty position for several years, he moved over to Merck Research Labs in 2007. He has several publications to his credit. He coordinates pharmaceutical trials in several parts of the world. He has a deep knowledge of Indian classical music, dance, and literature, and even writes lyrics for dancers. Welcome, Ravi, for always being there to support Marvelous Medicine. Over to you, Dr. Ramachandran.
Thank you. Thank you, Vidya, and thank you, Jayashree and Ravi. I'm really happy to be a part of this Chennai JIPMERites. And as I was talking to Vidya earlier, I never realized that there's so many JIPMERites in Chennai, even though I've been living in Chennai for so many years. Great. So I just, in the next 20 minutes, discuss about this exotic hot topic called biomarkers in diabetes. And we have always known diabetes as a disease of blood glucose, but we now know that diabetes is almost like a cardiovascular disease. And one of the most basic facts for the pathogenesis and causation of cardiovascular disease is atherosclerosis, and that is actually brought about and triggered by inflammation. So the question is diabetes an inflammatory disease? So let me see. What is a biomarker? In fact, there are a number of definitions for biomarkers, and biomarkers has become a very important hot topic today in clinical medicine and clinical trials. The NIH definition of biomarker is it's a characteristic that is objectively measured and evaluated as an indicator of normal biological processes, pathogenic processes, or pharmacological responses to therapeutic intervention. FDA definition is much simpler. Any measurable diagnostic indicator.
Sir, can I just interrupt? Are you moving your slides? If not, because your screen appears to be frozen.
I went to the second slide.
So you need to go on to slideshow and resume slideshow. So it's still on your introductory slide.
Sorry. Are you able to see the second slide now?
No, sir.
Let me go back.
Yes, sir. But could you please go to slideshow full screen, sir, because it's on.
You're not able to see now?
We can see it, sir, but is it possible for you to go to slideshow?
I went to the slideshow in my screen, but
okay. But we see the slide
okay.
on biomarker now. That's fine, sir.
Yeah.
Are you able to see now the second slide?
Yes.
But not in the slideshow mode,
Yes,
right?
yes, sir. Yeah, it's not in the slideshow mode, but we can see and read the text on it. So.
All right. If that is clear, that's fine. Okay. So the FDA definition is much simpler. Any measurable diagnostic indicator that is used to assess the risk or presence of a disease. In other words, biomarkers are not only predictive of a disease, but are also involved in the pathogenesis, and therefore modifying them has a potential to change the course or onset of diseases such as diabetes and even cancer. So a definition of an ideal biomarker should refine identification of those at risk of a disease, progression, improve prediction of complications of the disease, and or guide and help tailor responses to different therapies itself. So it's a high order. So biomarkers are important not only just for causality, but also progression, prediction of even complications, and even responses to therapies. Interest, of course, between the connection between biomarkers and cardiovascular disease actually came from the Framingham study. And they said that conventional risk factors do not fully explain cardiovascular risk. Biomarkers are new to identify persons who are at risk of cardiovascular disease. And we already been using these biomarkers in our daily practice now, like C-reactive protein, the natriuretic peptide, fibrinogen, D-dimer we have been using very heavily nowadays for the COVID patients and even homocysteine. The question is, how do biomarkers help in the field of diabetes? And I'm going to give you experience from our own studies in the India Diabetes Research Foundation in Chennai. Biomarkers for diabetes, in a way, should predict onset of diabetes in people who do not have diabetes. So that is the power of prediction. Biomarkers for complication should identify subjects with high risk of developing complications of diabetes, namely cardiovascular disease and even microvascular disease. Now, biomarker can also be added to conventional risk factors to improve power of association or prediction. Okay, so now we're going to look at pre-diabetes, a population at risk of diabetes. Now, pre-diabetes is an intermediate state before diabetes. All of you know that. We have both impaired fasting glucose, impaired glucose tolerance. Pre-diabetes is defined as a state with a high risk of not only diabetes, but also cardiovascular disease. Hyperinsulinemia and inflammatory states seem to exist in pre-diabetes. We only identified risk factors such as hyperinsulinemia, obesity, hypertension, etc. as a part of metabolic syndrome. But the new thing is that it looks as if the pre-diabetes also may be an inflammatory disease. So the question is, can measurement of inflammatory adipokines be helpful in identifying people at high risk of developing diabetes as well as cardiovascular disease? Now, Prediabetes, people with prediabetes develop diabetes, but the point is that not all of them go to diabetes. Many of them can reverse to normal in the natural history of prediabetes. So as in the Framingham study, we are now discussing whether biomarkers or pro-inflammatory cytokines can additionally help in predicting those people with prediabetes who have higher conversion rate to diabetes and also have a high risk of cardiovascular disease. In our laboratory, the biomarkers that we study in the last probably 15 years are adipokines, retinol binding protein, GGT and alanine transferase, these liver enzymes, interleukin-6, leptin, vispatin, and pituitary. Now, the point is that in order to look at biomarkers in diabetes and the risk of diabetes, you need prospective studies. And not many in India have prospective studies. We have been involved in primary prevention studies, and one of the first studies which Vidya mentioned that we did was called the Indian Diabetes Prevention Program. It was a prospective randomized control trial on primary prevention of diabetes in subjects with impaired glucose tolerance in the Indian population. And this is the design of the study. By the end of 3 years, we found that the cumulative incidence of diabetes was 55% in the control group, while it was 39.4 in lifestyle modification, 40 in metformin, and 39.5 in those with a combination. So every intervention seemed to have reduced the risk of conversion of pre-diabetes to diabetes. So the relative risk reduction for the interventions were 28.5, 26.4, and 28.2. Now, I'm not going to discuss about this now, but I'm going to discuss that this cohort was useful to our first study on biomarker in diabetes. And the next study that we did was what, again, Vidya discussed about was, we did a study on whether information technology or mobile technology can be used for a clinical outcome. And this was one of the first studies for using information technology for prevention of diabetes. So we looked at tailored mobile messages called the SMS, which we get every day nowadays, to encourage lifestyle changes which can reduce incidence of type 2 diabetes in those patients with pre-diabetes. This is called the Indian SMS study. And the design of this study was we recruited people with impaired glucose tolerance and randomized them into 2 groups. One is, of course, standard care, and the other one received standard care plus motivational messages. And it was done for 2 years, and the primary outcome was onset of diabetes. In fact, that gave a better results. In 2 years' time, there was a 36% relative risk reduction in those patients or on those subjects who received the SMS or the intervention. In other words, this is a much powerful study. The absolute risk reduction was 9%, and relative risk reduction was 36%. The number needed to treat to prevent one diabetes within the trial period was 11, which is a very cost-effective intervention. So these 2 studies gave us the cohort for the biomarker studies. So one of the first one was way back and published in 2003. In fact, this paper was published before we published the results of the Indian Diabetes Prevention Program. And Dr. Snehalada was the first author. This is published in the American Diabetes Association Journal, Diabetes Care, and we looked at plasma adiponectin. Now we know much more information on adiponectin. At that time in 2000s, we did not know much about adiponectin, but we knew that adiponectin is a hormone produced solely by adipocytes and is a regulator of glucose and energy metabolism. Low adiponectin is associated with low insulin sensitivity and can participate in the etiopathogenesis of type 2 diabetes. Now, we wanted to see whether it is true. And what you see here is that the incidence of the cumulative incidence of diabetes in different tertiles of adiponectin. What you can see is that significantly higher percentage of people in the lowest tertile of adiponectin developed diabetes, 56% compared to 12%. In other words, we concluded from this study that Indians who have pre-diabetes with a low adiponectin have a higher risk of converting to diabetes within a period of 3 years. The conclusion of the study was low adiponectin concentration is indicative of low insulin sensitivity and is a strong independent predictor of future development of diabetes in subjects with impaired glucose tolerance. The other one was mostly in studies, the SMS study, and this is done by one of my PhD students who's now working in the United States in Atlanta. This is retinol binding protein 4. For those who have not heard about this, retinol binding protein belongs to the lipocalin family and is known as a specific carrier for the delivery of retinol in the circulation. It is secreted mainly by hepatocytes, 80%. In fact, the correct name would be it is a hepatokine. And 20% is actually secreted by adipose tissue. So it is actually a hepatokine as well as an adipokine. And it may contribute to systemic insulin resistance and impaired glucose regulation. So the question was whether RBP4 predicts diabetes in the Indian population. And this is what you can see. This is the first model, adjusted, unadjusted, gave a odds ratio of 1.69. And the second model is the incidence of diabetes adjusted to age, body mass index, waist circumference, total glucose and triglycerides. Even after that, it gave an odds ratio of 1.73. And further adjustment to GGT and HOMA-IR, it gave 1.65. In other words, baseline serum RB4 levels was independently associated with conversion of pre-diabetes to diabetes after adjusting for all the variables which are associated with conversion of diabetes. This is a recent study again published in 2014. We all know that as clinicians, there is some connection between fatty liver disease and diabetes. So what we looked at was to study the association of baseline GGT and alanine transferase with incidence of diabetes in patients who had pre-diabetes. And we found that in the model 1, which is again GGT adjusted for age, body mass index, family history of diabetes, smoking, and we found an HR or hazard ratio of 2.18 between low median and higher median levels. The model 2, we further adjusted for total glucose value, HbA1c, triglyceride, and HOMA, and that gave 1.78. So in other words, it looks as if this particular hepatokine is also an independent predictor of diabetes. So GGT was independent predictor of incident diabetes, and it looked also that if you combine GGT with fasting plasma glucose, it then actually gave much more higher sensitivity. And that this particular study confirms that liver plays a role in the pathophysiology of diabetes, and whether correction of this metabolic abnormality could prevent onset of diabetes is a question. We again further, in the next cohort, we looked at leptin and interleukin 6 along with adiponectin, and what we found was that we know that interleukin 6 alters insulin signaling, and leptin is also associated with insulin resistance. So what we found was that adiponectin, again, we reproducibly produce a negative relationship between low adiponectin predicting diabetes. Iletin 6 adjusted for number of variables gave an odds ratio of 2.27, pretty high, powerful predictor. Leptin did not have any association. Now, if you can combine interleukin 6 with adiponectin, then it gave a sensitivity of 73.2 and 64.5. So as I told earlier, sometimes you can combine two biomarkers and that get better predictive value to actually predict a disease onset. This is one of the latest studies, and again, this is done by one of my latest PhD students. And this is association of visfatin and fetuvin A with insulin diabetes. These are pretty latest adipokines. Now, visfatin is produced by the visceral adipose tissue. And we all know that central adiposity or visceral adiposity has association with prediabetes and metabolic syndrome and can increase insulin resistance. It's regulated by hormones and cytokines influencing glucose homeostasis and correlated with markers of obesity and parallel increase with insulin in hyperglycemic states. Fetuvin A is actually a hepatokine and is elevated levels in again obesity and type 2 diabetes and in metabolic syndrome. So we wanted to examine this. There were only couple of papers on this from the West at this point of time, and nobody had looked at a prospective study in order to see the association and the predictive value of these hepatokines and adipokines in the onset of diabetes. This is showing you the incident diabetes in relation to baseline tertiles of visfatin. And as you can see in the bottom, the tertile 3, this is a 54.2% incidence of diabetes compared to only 13.9 in the lower tertile, showing that visfatin had a predictive value in the onset of diabetes. This is fetuvin, which is a hepatokine, and in tertile 3, there is a 55.6% cumulative incidence of diabetes compared to 12.5 in the lower tertile, showing again that fetuvin has a predictive value in the onset of diabetes. This shows you the ROC curve, just showing that sensitivity and specificity pretty high for the predictive value of fetuvin A. And this is the ROC curve for visfatin, which got a sensitivity and specificity of both 75%. So pretty powerful predictors. Now, as I told you earlier, sometimes when you combine two biomarkers together, you can get a very powerful prediction model. And what you can see here is a combination of both visfatin and fetuvin gave a odds ratio of 12.63, which is a very powerful prediction. About 12 or 13-fold increase in the risk of diabetes if you have both these two, adipokine and hepatokine, higher in the higher tertiles. Now, metabolic syndrome is another hot topic, and we found that even in our study that these two hepatokines and adipokines are also associated with not only diabetes but also metabolic syndrome. Now, just to give you a couple of other studies. Now, so far I talked to you about the studies that we had done in Chennai in our own laboratory. The other study where adiponectin and E-selectin, two adipokines, were implicated was from the American Diabetes Prevention Program. And that they wrote this title as Non-Traditional Biomarkers and Incident Diabetes, the Diabetes Prevention Program. And this was published actually in 2019, much later after we published our adiponectin paper in 2003 in the prediction of diabetes. They actually found 3 important adipokines: E-selectin, adiponectin, and tissue plasminogen activator were associated with incident diabetes compared to the placebo group. Now, in Germany, there is a study called the Monica-Cora study in which they looked at not only just diabetes, but they took a combination of biomarkers in order to predict not only diabetes, but also mortality and heart disease. And they found that a number of, in fact, iletin, IGF-BP, selectin, adiponectin, HDL cholesterol, and dicorin all improved the prediction of type 2 diabetes. So this is published very recently in April 2021. In fact, the interest in the biomarkers and adipokines are increasing because it is not only predicting, but also telling you the pathogenesis of type 2 diabetes and cardiovascular diabetes and how they share the inflammatory process in their pathogenesis. We can also use, this is again a paper from the cardiovascular outcome trials done in diabetes called the Sms Study, in which what they looked at was they actually calculated and derived what is called a prediction scoring system for heart failure with and without diabetes. And on the left-hand side, they actually derived the scoring system from one study, which is called the derivation cohort, and then used it in a validation cohort in a different study and found that the score really predicted heart failure in people who were in the clinical trial. So therefore, this scoring system with using these two biomarkers could be used in prediction of heart failure. I'm just giving an example. So far, I talked to you about diabetes and cardiovascular disease, but this is about heart failure. So conclusions from our studies on the biomarkers in predicting diabetes said that the high levels of pro-inflammatory cytokines and biomarkers in those with pre-diabetes who develop diabetes indicate that they have a role in the pathogenesis of diabetes. But more interestingly, diabetes seems to be an inflammatory process or inflammatory disease, and the process of inflammation seems to be starting even at a pre-diabetic stage of the natural history of diabetes. In other words, this actually explains why diabetes has got a very powerful association with atherosclerotic process and cardiovascular disease. And then even people with pre-diabetes have a high risk of cardiovascular events. The measurement of biomarkers can identify people with high risk of diabetes in those, and then you can target them to prevent diabetes. Because even when you have pre-diabetes, some of them can reverse normal, so it fully does not explain the risk of diabetes. The association of some of these biomarkers, again, with cardiovascular disease probably indicate that they have a role not only in the development of diabetes, but also in the complications of diabetes. So therefore, in future, whether it is possible to identify people at high risk of complications of diabetes. Today, as endocrinologists, we know that it is very difficult to know who are the people with diabetes who have a high risk of complications of diabetes. Some of them escape the complications, and probably this can be explained by the biomarkers. The future success of biomarker strategies may depend on the discovery of new biomarkers to complement the best existing ones, perhaps with the help of new unbiased approaches in the future. So thank you. I didn't want to take more time. These are my, this is on the left-hand side. This is my research team and Director Dr. Snehlata, and we have a clinical team, and I have several collaborators. Some of them in the prevention trial have been Jaakko Tammerto from Finland, Des Johnson, the Dean of Imperial College London, and Professor Nick Warren from MRC in Cambridge in the United Kingdom. Thank you very much.
Thank you so much for that lucid talk, Dr. Ramachandran. Over to you, Ravi Shankar and Dr. Jayashree.
Sorry, I think we're both on mute. Jayashree, go ahead. Yeah.
Yeah. No, go ahead. You can start off.
Okay, thank you, Dr. Ramachandran. That was phenomenally educational, and thank you so much for presenting, a very, huge corpus of data on Indian patients and what is important in the Indian context. Because one of the suggestions that we got for Marvelous Medicine was to make all topics relevant to India, not just focus it on data from around the world. So I cannot think of another example of how wonderfully it can be done than this talk. So thank you so very much. And obviously, I have been very aware of all the work that you've been doing for a very long time. So I'm not surprised at the quality and the phenomenal clarity of all the conclusions that you presented. And I agree with the contention and your conclusion that diabetes is an inflammatory disease. I think obesity per se is an inflammatory disease. I think adipose is an endocrine organ that contributes to inflammation of any kind. So if you look at across systems, any sort of inflammatory disease, be it juvenile rheumatoid arthritis or chronic inflammatory bowel disease, obese people have a worse time with the disease because they have a higher degree, a higher load of inflammation. Based on what I understand, that a lot of the inflammation and inflammatory pathways sort of converge through the conserved family of genes and gene products called sirtuins that eventually affect how diabetes and other cardiovascular risk factors evolve in this population. And unfortunately, some of these enzymes need to be activated for them to become really good druggable targets. And enzyme activation is very difficult it's much more difficult than inhibiting an enzyme. I will not go into the technical details, but as someone who works for a pharmaceutical company and is involved in making drugs for people, it would be wonderful if we could somehow target that and help go to the root cause rather than just treat the ultimate effect, which is high blood glucose, which is what we've been doing. Although the newer classes of agents like SGLT2 inhibitors and the GLP-1 receptor agonists are doing many more wonderful things to patients in addition to controlling their blood glucose. So, obviously my interest is very much driven by how can it be used to help patients. And unfortunately, it seems to be a problem with, how to activate an enzyme consistently, etc. So, I really, once again, would like to thank you for this wonderful talk. And also thank you for all the efforts that you and your team are taking to debunk this myth that type 2 diabetes is Sakkara Vyadi. I think that is the one big disservice that we have done to our patients because they are so focused on glucose and become so glucocentric that they forget that diabetes is, the blood glucose is an important part, but it's only a part of their disease. So thank you so much for that. And with that, Jayashree is, I'm sure, will have some very important clinical insights that can be used from this information. Thanks, Jayashree.
Thank you.
Thanks. Thank you very much. And Dr. Ramachandran is my teacher. I don't think I can really say anything. Always, we've been learning over the years. And I see a comment in the chat box. Dr. Ramachandran really is a pioneer in studies in India. For those of you who do not, he is a pioneer in making us understand how diabetes develops and the demographics. And like he pointed out, the study that he did, the Indian Diabetes Prevention Program, I think, maybe you can share some insights later, Dr. Ramachandran. I remember you saying that initially they thought that it couldn't be done here and all the difficulties that you had to face. And I remember at one of the talks when we met, you were discussing briefly about it. So it would be interesting to tell us the practical experience, because the first thing that pops up is they say, no, in India, we can't tell them to eat less. We can't tell them to exercise more. And you prove that it could be done, in a regular population, and you could reduce the incidence of diabetes. So I think that was important. In fact, I just wanted to share, I think what Dr. Ravi Sanchez said just this evening. I was talking to a patient who, had a HbA1c of 7.7 in 2003, and since then has maintained, he's only 46, and since then has maintained it around 6.2, 6.2. And he said, "Is that good, doctor?" I said, "It's okay, but I still wouldn't put you out of the risk category." And I was saying for us, for diabetologists, for me, it doesn't make a difference if it's 6 or 6.5 or 7 or 8. For me, that's, the glucose intolerance extends across all the spectrum, because we understand all of the connotations related to a HbA1c of 6. He is only seeing the blood sugar and maybe thinking about his kidney and his eye and his foot, like you pointed out. And I'm thinking about the cardiovascular, the inflammation, the cancers, the arthritis, the dementia, the depression, all the things that goes in with insulin resistance and carbohydrate and whatever you call it, some sort of a metabolic disimpact. So absolutely right. I think we have to urgently rename this disease, at least in Tamil, from, I don't know what, some equivalent which says inflammation. First of all, it's very difficult to find a Tamil word for inflammation. So Neruppu Mari is the closest I can get to it. Slow burn. That's the only thing I can think of, a slow burn. So, it's absolutely terrible, but I can't think of a better word. I was just curious, Dr. Ramachandran, have there been studies done looking at the effect of weight reduction and exercise on these markers? Has it come down? Have you looked at that?
No. Okay. You're just talking about telling in Tamil inflammatory disease. I think it's better to describe diabetes as a cardiovascular disease. I mean, inflammatory disease is difficult to explain. So you're going to tell patients that diabetes is not just Sakara Vyadi, it's a cardiovascular disease. Here. And the other point that you said, that when you have a 6.2 and the patient continues to be with 6.2 for many years, you keep telling him from your theoretical knowledge that he has a high risk of developing diabetes, but you see that he doesn't develop diabetes at all for a pretty long time. And then he doesn't get any heart attack, he'll be okay, he lives long up to the age of 85, 86. But that is the point. Now, we are measuring one number and telling that he's in a pre-diabetic stage, and we know that people with pre-diabetes, statistically speaking, have a higher risk of diabetes and cardiovascular disease. However, 30% of them will reverse to normal, 30% will remain as IGT, another 30% will develop diabetes and cardiovascular. So therefore, that gap, whether that can be filled, that knowledge gap can be filled by additional measures like biomarkers. And that is the point. And that is exactly what the Germans are doing, and that's exactly what in the US they're trying to do, whether the unexplained risk not quantified by the conventional risk factors can be explained by inflammatory markers, which we never knew earlier. Now, the problem is that every week or every month, I think Ravi will know this, that a new biomarker is being described, and there is a plethora of papers on biomarkers, but not many of them have prospective studies, and that's the point. And as you rightly said, doing prospective studies in India is really a challenge. There are many difficulties, and as you know that even with people with diabetes do not come back to you for regular checkup, how do you think people without diabetes will remain in a study for a randomized controlled trial? But do you know that many years ago when I went for a research methodology course in Cambridge, one of them told me a sentence which I still remember. They call me Ramu. Ramu, when you design a study and you find it is a difficult study to do, you must remember all difficult studies are worth doing. And that is important. So if you want to really do good studies, you have to take a lot of pain and effort, and you have to be ready with a lot of fights to go through with, nowadays we need a lot of regulatory bodies to give you all the permissions. So it's not that easy. And I had so many studies which went to the DCGI, CMR, which were turned down, and which were done later by the Japanese and the Koreans. Unfortunately, the question that you asked about central adiposity, in fact, I must talk about Merck. I was in New Jersey about 10 years ago when Merck asked me when the DPP-4 inhibitor first came. I think there was a meeting in New Jersey, and we were thinking of doing a prevention trial using DPP-4 inhibitor. And at that time, DCJ turned down. You know, the reason why they turned down, they said DPP-4 inhibitors produce pancreatitis. So you cannot afford to give that for pre-diabetes. I mean, I mean, within a month, the Japanese started a study and they showed that they can prevent. Anyway, so that is, so to answer your question, we do not have studies now to tell you about whether biomarkers have been used for patients with who had only exercise and weight reduction. But definitely my guess would be that if you do dieting and if you do exercise, and even if you lose weight or even if you do not lose weight, this is a powerful tool to reduce insulin sensitivity and also reduce fatty liver. And therefore, definitely, they will have a mirror effect on the adipokines and hepatokines. I think you can, but you need all of them. You can only, you have to show it by studies, very right. There are a few questions in the chat box. Vidya, do you want me to address that? Yeah,
yes, sir.
we're talking about validated in North Indians and South Indians. All the primary prevention trials and the study which I told you was done both in India, mostly in Tamil Nadu and also in Andhra Pradesh. So I do not, my guess, my gut feeling is that there is no big difference between North Indians and South Indians except for the obesity levels and the prevalence of diabetes. But actually the phenotype and the genotype of the people in the whole Indian subcontinent, including, I can tell you, Pakistan, Bangladesh, and Sri Lanka, and the whole Indian subcontinent is pretty the same. The South Asians behave the same way because if you control for socioeconomic factors, the prevalence of diabetes is pretty same in almost all these societies. So I do not find there's a big difference. Of course, we have the normal values for the normal population, which I can share with you from our paper.
Rajita, you want to say something?
Yes, ma'am.
Go ahead.
Good evening, sir. Sir, I belong to the undergrad batch of 93. I am a dermatologist. And my interest in this topic comes from my experience with treating psoriasis patients, but also a lot of acne, including adult acne, which has been linked to insulin resistance. I see a lot of PCOS patients who come with adult acne, hirsutism, and female pattern hair loss. And because of this, I started getting into a lot of HOMA-IR and all. The problem that we face is that insulin assays are very poorly standardized. If I send the same sample to 4 different labs, I could get like a 4-fold difference. I'm sure you know that already. So for somebody like me, if I want to convince my patient that they have insulin resistance, I use the HOMA-IR. No, because I am not a physician, I am a dermatologist. And I do want to make them lose weight to attain a BMI of 23. We go as far as measuring visceral fat. We look at the DEXA. We have a inbuilt device. We look at percentage body fat. So we do all these things. We have serial measurements, and we work very hard at educating them about number of minutes of exercise per week, target heart rates, number of grams of carbs, all this thing. But to give them metformin is something that is impossible because people think it is a sugar kadawa. And most of the endocrinologists that I refer to, other than the few gypmarites who are accessible, some who are not okay to prescribe metformin. So I'd like to hear your comments on that. And is there a way out, maybe using something like adiponectin, something that, do you think this is going to come into the general parlance? Is it ever going to be an option to HOMA-IR? Is HOMA-IR the way to go? Is there a particular way of getting it right?
Okay, good question. It is not necessary to always do HOMA-IR for clinically diagnosing insulin resistance. Now, we have got a paper which we have published, a surrogate marker for insulin resistance. If you look at the waist circumference, and the next thing is the triglycerides. If you combine these together, you get a better sensitivity for insulin resistance than even doing in a HOMA-IR. So therefore, Rajita, please do not spend too much of time on HOMA-IR. Of course, the problem with the HOMA-IR is that the insulin values can change from day to day, from time to time in the day itself, and it also depends on the blood glucose levels. And therefore, HOMA-IR is a very good value to go with, but you may have to do probably repeatedly, couple or 2 or 3 times in order to find the value. But the exact value of HOMA-IR has no implication to treat insulin resistance. If somebody had central adiposity and high triglycerides, you can clinically diagnose insulin resistance and treat. And what is treatment of insulin resistance? It is lifestyle modification, as you rightly said. And anybody can take metformin. If you want to give metformin, you can give metformin. It will always do good. Okay, I hope I am trying to answer your question.
Thank you, sir.
Can I add one more thing? I totally agree with you that insulin assays are terrible and not very reproducible. But C-peptide assays are thankfully better. And you can use C-peptide and glucose values to derive HOMA. The UK PDS HOMA2 calculator will allow you to do that. So you have a drop-down menu to choose between insulin and C-peptide. So you can use either one of those to get your values. But I think Dr. Ramachandran is absolutely correct. A single HOMA value is really not going to tell you much. You know, it's and for the most part, my experience is that you know, you really don't need subtle markers to convince your patient that they have insulin resistance. It actually hits you in the face. I mean, as Asians, we do have a higher propensity to develop acanthosis around the neck and the axilla. So you'll have visual clues to point out about insulin resistant skin tags around the neck. Practically everybody has it. So it's really not all that necessary to go into very detailed things like HOMA-IR. The point is that a lot of the things that Dr. Ramachandran has mentioned and many of the you know, these large cohort studies show us are two things. One, these are epidemiologic things. I mean, they really, to convert them to clinical practice requires, I think somebody in the chat box had said, you know, normative data, cutoffs and all that stuff. That hasn't happened. Secondly, the assays have to be phenomenally standardized. Like you just mentioned about insulin, that's true of adiponectin. That's true of, and adiponectin, are you measuring the, you know, the global, you know, the spherical form or globular form? Are you measuring free assays for the particular biomarker that you're looking at? It's highly complicated, and I really don't think that translating it into clinical practice is that easy. What it really tells us is that these are all things that people have to work on. I mean, Dr. Ramachandran has set the standard for the Indian population. I hope that other people will now work on how to standardize its clinical care through studies, not through, you know, I think it is, or, you know, try to say that this has to be that way. But it is something that has to be kept in mind. Translation of a lot of the epidemiologic markers takes time. It's only now, I think in the past, I mean, the Framingham Heart Study has been going on for ages, but it's only in the last, say, 20 years that even lipid profile measurements have been standardized across the lab. So if I get a you know, LDL cholesterol in India of 120, it's probably going to be the same if it's measured in a lab anywhere else in the world, you know, within you know, inter-assay variabilities, etc. But having said that, until that kind of standardization happens, it is going to be difficult to say, hey, this is the level that's bad. What is more important is this level, if you follow it through, you know, if it remains high, that is bad. If it goes down, you're doing something good, keep at it. You know, at least that's my take on it at this time.
Yeah, I think just I want to add that we have actually in our laboratory, we stopped doing insulin. We do only C-peptide now. I didn't want to add that point. So Ravi, I will just tell a joke. You know, you said about the HDL value. One of the best ways of reducing your cholesterol is to change the laboratory. that's a joke. But I think Rajita has a point. Some of the Indian patients, they want to see a number to change their behavior. That's why she wants to show them some of the HOMA-IR value. So now you can show them the waist circumference and centimeter and say this is the normal and the triglyceride value is positive. And then, of course, we can do C-peptide also.
I just wanted to add to what Dr. Rajita said. This was brought home to me very recently. No matter what we say in terms of your acanthosis is bad or your base circumference is bad, So I had measured CRP for one of these women. I mean, I started doing that more. So I also measured the CRP, the uric acid, the AST, ALT, and the PCOS, and the CRP was high. And maybe because CRP is so much in the news now because of COVID, so this girl got very worried about it. And I said, no, go back, lose weight, come back. But like Dr. Ramachandran says, sometimes it's helpful to have, not that I'm saying you go do it for everybody, but I realized the value, because that seemed to shock her more than anything else I was telling her. She just got shocked because of that. So I fully understand what you're, trying to look for, or to try to tell them the importance of all of the things we tell them.
Thank you, ma'am. It's very ironical that for everybody other than a dermatologist, acanthosis nigricans means insulin resistance. For us, it is pigmentation. And it's sadly started. So if you're a physician, you're an endocrinologist, we were actually sued for prescribing metformin for insulin. We got away, of course, but we were actually sued once.
I want to tell something to Ravi. Ravi, the latest one of the PhDs that we are now doing is, my daughter is a periodontologist. So we are now looking at salivary adipokines as a surrogate marker for the adipokine, salivary adipokines as a surrogate for the adipokines in the serum. And there's a very good collaboration on that. And that's actually getting published probably next month. So you don't have to take the blood sample. You actually adiponectin value from the saliva. You must know how to collect the saliva. So it's a very, very non-invasive technique. You just take the spit and take to the laboratory and look for adiponectin, or you can look at bisplatin or anything. So this is a new thing, very new, and there are only a couple of papers published. So we have one of the first papers coming out on this.
So that'll be fantastic, particularly for pediatric endocrinologists who want to do this in kids. So yes, absolutely, that's fantastic. Congratulations.
Sunny George, would you just like to unmute and speak? I know you've been typing on the chat box, but we'd like to hear from you. Sunny George, you there?
I am right here, ma'am, but unfortunately I am down with the COVID, so I would rather like to hear the experts speaking rather than interacting. Kindly excuse me.
Yeah, no worries. I just thought you'd like to present your question yourself. Nevertheless, I'll just read out. Since there's a lot of ongoing inflammation, and given the knowledge that chronic calcific pancreatitis can land up a person being insulin dependent, do you think that there is a chance for a chronic viral infection, or still an obscure cause for developing diabetes rather than only genetic predisposition?
Of course, I think this is very well known that viral infections can produce type 1 diabetes, but the only thing is that those people who have genetic predisposition have an increased risk. Now, there's a new thing that COVID also produces new onset diabetes, and that is a new big registry, global registry, which we are a part of, where we have found that they also have antiviral antibodies, as well as some of them have anti-insulin and anti-microsomal antibodies and they produce diabetes. But chronic pancreatitis is what we're talking about. Calcific pancreatitis is an entirely different cup of tea. We're not talking about that. We're talking about insulitis, that is the inflammation of the islets of Langerhans. Chronic pancreatitis, this is a different chronic disease which is occurring in malnutrition and toxic factors, usually in the West due to alcoholism. In our country, we had a lot of malnutrition and cassava, etc., etc. So it is not chronic pancreatitis. We're talking about type 1 diabetes is occurred because of insulitis. It can because of viral infection or autoimmune disorder. Okay, I think that answers the question. Recurrent pancreatitis is a reason for diabetes later in life. Yeah, of course. Patients now it's looked like this. The gene load or the gene pool for type 2 diabetes in our population, especially in the urban population, is pretty high. Now, if you look at urban population, 21 to 22% have diabetes above the age of 20 years. So when you get repeated like the pancreatitis, then you unmask the diabetes much faster. So there are two conditions. One is pancreatitis per se producing inflammation of the islet is producing diabetes. But more importantly, pancreatitis unmasking people who have a genetic tendency to develop type 2 diabetes that prepones your diabetes in your natural life history. Okay, I think I hope. Have we really hit the etiology yet? Of which one? Of type 1 I'm talking about? Type 1, we know the etiology to a large extent. Type 2, we're still in the dark. We only know the risk factors, not exactly. We know the genetic factors for obesity, but the genetic factors for type 2 diabetes still a lot of conflicting papers are coming. Okay. Okay, Vidya.
Yeah, something that Sunny said earlier, we've already discussed, but just to reinforce that, it's really encouraging to get a biomarker package which can be applied on a yearly basis for predicting cardiovascular disease in diabetics, probably, and line listing them for our cardio colleagues and better lifestyle modification. We are not close to that yet, isn't it, sir? That's what we concluded.
Yeah, I think for heart failure, they have a scoring system using those two biomarkers. But the point is that I think Ravi will know this. I'm involved in the steering committee of many of the global trials. The FDA has now made it almost mandatory that all clinical trials, biomarkers have to be there as a part of their measurements. And they actually, they want biomarkers to be a part of the consequences of any intervention trials that you're doing, whether it is drug trials or any other trials, for cardiovascular disease, for cancer, for all kinds of. So biomarkers have become so important that it's mandatory to do that for clinical trials. However, the formula for exactly predicting a cardiovascular disease or diabetes is still in a very primitive stage. We are all researchers in this part, so we will come out with probably scoring. We will be able to do that pretty soon.
Right. Any more comments, Dr. Jayashree, from a clinical side rather than the research side of it?
Nothing as of now. Nothing.
Right. Giri, you wanted to say something? No. Right. Radhakrishna, any clarifications you want as a surgeon?
It's always nice to see intellectuals talking, and for surgeons this is something from a distance, but there are a lot of information I could get from this, and especially I'm really interested in what George was asking about biomarkers for cardiovascular risk in diabetic. We see a lot of diabetes in our surgical practice, although we don't go into the details, and it's so heartening to see Jipmarite doing so much research from Indian soil, Indian publication. Is a privilege to listen to all that, and it's a wonderful talk, I should say.
Any concluding remarks, Dr. Ramachandran?
Well, the concluding remark is I am proud to be a Jipmarite.
We are proud.
Yeah, Vidya, can I add something? So yes, we're all proud to be Jipmarites, and Dr. Ramachandran happens to be one of the reasons why we are. And one thing that Vidya, you didn't mention in the introduction is that today diabetes research from India is practically synonymous with Dr. Ramachandran and maybe a couple of others. And that's how, in a country that's that huge, to be the leading investigator and practically the face of diabetes research from India is not easy. So I think we did not get the exact amount of work and the elbow grease that Dr. Ramachandran has put in to create anything. I mean, he made it sound like, establishing a database is so easy. No, it's not. And then particularly getting people to follow up. I think Jayashree mentioned that. We may need a separate session on how exactly to do it, because that's a phenomenal skill that I think is required if further prospective studies are to be contemplated and done. So I think we really have to hats off, sir, for making it seem so easy. That's what everybody does, right? So
thank you. Who is this talking? Who is this? I am not able to see who is it Ravi?
Yes,
yeah,
sir.
It's me.
It's
yeah. So
okay.
you make it sound like Federer playing on a tennis court. So, and we all know that.
When you tell the results of a trial, like for example, the IDPP, we took 1 year for recruiting people and 3 years to finish the study. But to give the results of the final results, you need only 30 seconds to show that slide. Now that 30 seconds took 4 years to produce that slide. So that's exactly what you're telling. The amount of work.
Exactly. Yes, exactly. So it's like not even the tip of the iceberg. It's like a pinhead on top of the iceberg. So it's just phenomenal how much work goes into it. And, and he's made it sound so easy. So I just wanted to let people know that it is anything but easy.
That's all the more reason why I'm so grateful that he took time out from such a busy, career to spare time for a sort of unknown program like Marvelous Medicine, when he'll be probably talking at all the major international fora. So thank you very much, sir. And we'd like to trouble you again in probably a few months from now to we've done some sessions on what kind of journals to read and how to we've had sessions on how to write a paper, how to get it published, and how to interpret randomized controlled trials. So we'd be very grateful if you could do a session on how to actually do the trial sometime in the coming months. So if anyone else has any questions or comments, please go ahead. Otherwise, we are ready to close.
Vidya, at this point of time, I must share with you, my interest is actually in telemedicine. I think Jayashree also probably knows that. For the 6 days I see clinics, 5 days are sitting at home, but I can reach patients anywhere in India, do blood tests anywhere in India. And we have now got a new clinical, what is called app, which can be downloaded into the patient's mobile phone and have a face-to-face video consultations. And it has become very popular. I will share with you this another day.
Dr. Muthu wants to say something. Muthu Jayaraman.
Dr. Ramachandran, it was a great talk. You said diabetes can be called as cardiovascular disease, and the biomarkers are pointing towards it. But as you know, kidney disease also equally common, and nephropathy, diabetic kidney disease, is one of the reasons for the cardiovascular disease and the mortality. Do you have these biomarkers, any of the biomarkers showing that this particular person may develop or may not develop kidney disease? I would be very interested to know.
Yeah, a very interesting question, ma'am. I think I never knew that you are there. Okay. Yeah, of course, chronic renal disease in diabetes is under recognized. You know that, you already know that. We'll have to catch these people when the EGFR comes down. I do not have data on predicting kidney disease and biomarkers. As I told you that we have done this in prospective studies in patients in whom we have done prevention trials. But I think in future, the next thing would be that in diabetes, whether we can predict complications such as kidney disease, cardiovascular disease, retinopathy, or etc., using specific biomarkers. That will be very, very interesting, and we do not have at the present any data on that. But your question is very, very valid.
Because clinically, you see the heart and kidney go together in a diabetic complications, almost.
Correct.
And they progress together. And one of the reasons for mortality is a cardiovascular death. So I thought these biomarkers can also indicate kidney disease.
Yeah. What you said was that you are seeing patients when they already developed almost chronic renal disease.
Yes.
And then anybody who has developed chronic renal disease and diabetes have a very high risk of cardiac events, cardiovascular events. But our interest is that we have, Ravi will and Jayashree will know, We have patients, 20 to 25 years of diabetes, who have not developed kidney disease at all. So we do not know who are at high risk of developing nephropathy. And this is our interest to see whether biomarkers can predict specific complications, in which case we will be able to be more aggressive in those patients to prevent those complications. Thank you.
That would be great. Thank you.
Sir, if you have the slide ready, or if you could just write about the app on the chat box, whichever, right away, sir.
Yeah, I think my slide had shown that this is called DIAHOME, DIAHOME, Diabetes Care Comes Home.
If you could just flash that slide again, sir. Is it possible?
Let me see where it is there. Let me see. I have it. Yeah, there you go.
DIAHOME, right. Thank you, sir.
The point is that in Chennai, we can do lots of things, not only just blood testing. They will come home and do the height, weight, blood pressure, blood test, any blood test you want, it's come to the laboratory. And we can do ECG at home. We can also do the test for biotestsimetry and Doppler in the legs. And we do a non-mydriatric fundus photography. So it can be like a virtual visit to the hospital. And elderly, your mother-in-law is sitting at home who is 80 years old. She wants to have a diabetes checkup and a ECG done. Just download DIAHOME. They will call you.
Right. Thank you so much. Thank you once again for not only sparing your time, but making such a difficult topic easy for all of us to understand. Because a Marvelous Medicine, we have people logging in from all parts of the country, sometimes other parts of the world as well, belonging to various subspecialties. So we try to make it, interesting to all medical people. So thank you so much for this important talk. And like I said, I will be back to you again to request you for another talk in the coming weeks. We will meet again next week with another episode of Marvelous Medicine. Till then, take care and stay safe. Good night.
Good night. Thank you.
Thank you.
Thank you, Ravi. Thank you, Jeffrey.
Bye.
Thank you, sir.
Thank you.
Bye-bye.
Thank you.